Good morning, everyone, and thank you for joining me virtually here today. I'd like to welcome all of the conference delegates to the fourth day of the BC Care Providers Virtual Conference, as well as thank you for our sponsor, Maxwell Management, for making today's discussion possible. Today, we're going to focus on the issue of health human resources in seniors care and living, and in particular, how it relates to COVID. Before we get into our discussion, I'd like to introduce our conference panelists. First, we have Shirley Sharkey, who is the president and CEO of SE Health, which is one of the leading providers of home health services in Canada. Welcome, Shirley.
Thank you.
Second,
pleased to be here.
Yeah, you're welcome. Yeah. Second, we have Christine Sorensen, who is the president of the BC Nurses Union. Christine has recently been re-elected by her peers to serve as the president for another term. We want to take this opportunity to congratulate her and welcome her today.
Thank you. Glad to be here.
Third, we have Brian Gay, a healthcare assistant who works at Menno Place in Abbotsford. In addition to providing care to older adults, Brian is also a provincial violence prevention facilitator, a big mouthful, for Safe Care BC. Welcome, Brian.
Good morning. Thank you for having me.
And last, but certainly not least, we have Lisa Levin. Hope I pronounced that right. Lisa is the CEO of Advantage Age Ontario, which is a leading association for nonprofit seniors care and housing providers in Ontario. Welcome, Lisa.
Thank you so much. Happy to be here also.
All right. Well, let's get into our discussion today. I'm wondering if we could get you to all introduce yourself, and when you do that, explain why you wanted to participate in today's session. Christine, I'll start with you.
Great, thank you. Hi, everyone. My name is Christine Sorensen, and as it's been introduced, I am the president for the BC Nurses Union. I also am a registered nurse and have been a practicing registered nurse for 31 years, primarily working in the area of public health. Why I was interested in participating in this panel is because nursing is an integral part to the care that is provided to our seniors population, both in community, acute, and in our long-term care facilities. And BC Nurses Union represents about 48,000 nurses across this province, and about 13% of nurses work in long-term care facilities across Canada. So it's really quite important to me that that nurses are at the table in these discussions regarding seniors care in long-term care facilities, and that we participate in the discussions and our perspectives are heard. So thank you for the invitation.
Thank you. Next, we'll go to Lisa.
Okay, thanks so much. So I run an association called Advantage Ontario in Ontario, and we're a provincial association. We've been around 100 years, actually 101 years, and we represent not-for-profit long-term care homes and seniors housing providers. And we have around 400 full members. So I would say health human resources is one of our top issues and top asks that we've had for many years with government, because the sector is underfunded, there aren't enough staff, they're underpaid, they're part-time, some of them are working precariously, and this is an area that we need to fix now, and we've needed to fix for years. So as we're going to talk about in COVID, it's made it even worse and has exposed the issues related to that. So this is a really critical topic, and I'm happy to be here today to talk about it.
Thank you, Lisa. I'm looking forward to hearing the Ontario perspective in our discussions. Shirley, let's go to you.
Thanks so much, Hendrik. I just am delighted to be here, and I am privileged to actually be the CEO of SE Health, and many years ago we were known as St. Elizabeth Healthcare. I actually have a nursing background, and when I started, worked as a visiting nurse. And so that's why many years ago, I was very keen to move into home care and community care in leadership role. St. Eliz, SE Health is really, our vision is really simple, promoting and creating hope and happiness for people. And certainly the seniors population is a big group that we provide care throughout the country and in their homes, however they may define what their home is. Why I'm so keen to be part of this discussion is healthcare is really all about a human care system, all about people. And so it is so critical that we make sure we understand our talent and what we're trying to accomplish, because that's really the only way we're going to see the bigger, what I would call social impact that's necessary for seniors. So I'm delighted to have the focus in the conversation where it really should be, and that's really about people and people in our system. So thank you.
Thank you. Thank you. And Brian, give the last word on this question to you.
Great. Well, once again, good morning, everyone, and thank you very much for including me. My name is Brian, as I said. I work at Minnow Place and have been in healthcare for about the last 15 years or so. Minnow Place is in Abbotsford. We have about 700 residents. I am a healthcare assistant, and I also work in multiple sites, or did up to the COVID, and have watched the staffing shortage and seeing the detriment that it causes to the sites and at the end of the day to the care for our seniors. And I agree with everyone else. This is a very important subject, and I'm glad we're discussing this. COVID has certainly brought it to the forefront. The need for staffing levels to be increased and for the recruitment of staff. So once again, I'm very happy to be a part of this, and thank you for including me.
Thanks, Brian. Thank you, everyone. So we're going to get into talking about staffing shortages. I think that's, as Lisa mentioned, that's a key thing to our experience in COVID. And I think most audiences know, people that are watching this will know that, how COVID is sort of unfolded throughout the country in Quebec, Ontario, and even here in BC. But I think it's important for us to, talk a little bit about that. And Lisa, I want to start with you. Maybe you can give a brief explanation how the staffing shortages have contributed to the degree of outbreaks in long-term care in Ontario.
Sure, thanks so much. I would say that it certainly did not help the situation that at the beginning of the pandemic, we were in the middle of a health human resources crisis in Ontario, which was definitely worse and is definitely worse in our more northern and rural and remote areas, but has affected the entire province. And there also has not been enough funding for enough staff in homes to meet the acuity of the population in today's long-term care homes. So homes were already operating, working short. There were not enough staff even to fill their regular shifts. And on top of that, because of burnout and the challenging working conditions, there was high absenteeism. Then on top of that, at the start of the pandemic, people were still allowed to work in more than one location. Only 50% of the staff working in long-term care in Ontario work full-time. The rest work part-time, and many of them work in other settings, primarily healthcare settings. So that meant that people were going from one home to another, and it wasn't until April that the government finally started publishing where the outbreaks were. So you may not realize that you have a staff person working in a particular home that's had an outbreak, and now they're coming into your home and potentially bringing COVID with them. So that was certainly a factor. The other thing is that once a home did go into outbreak, what we have seen is that they have lost large amounts of staff. So the obvious reason is if the staff themselves are ill, or if they have come in contact with someone else in the home, staff or resident, volunteer, visitor, who has COVID. And so then they would have to be off quarantining. Then on top of that, staff also, their children weren't in school because schools were closed or their daycares were closed. And now schools are back open again, but they are closing one by one when there are outbreaks, it seems to be. So that's an issue. Many staff were afraid. They were concerned for their own safety, particularly at the beginning when there weren't always enough PPE and we didn't know what COVID was. But even now, we know it can be deadly. Or they're concerned for family members they live with who are vulnerable for various health reasons. And then the other piece of it is that we have to realize that personal support workers, which is what we call them in Ontario, they're not regulated. And I don't know about BC. I don't think they are. And I think that also makes it more challenging to deal with a situation such as an outbreak. So those are all the different factors that contributed to the outbreak situation in Ontario related to
Thank you.
HR.
Yeah, thank you. I want to turn to Brian. Brian, I want to get your perspective, being a healthcare aide, being obviously coming from a site that provides dementia care. How has staffing pressures, staffing shortages affected the ability of frontline healthcare team members from caring for residents who have, significant deficiencies due to dementia?
Right. Well, first of all, I'll echo everything that Lisa said. And prior to the COVID, we certainly had a staff shortage issue and causing, as Lisa was saying, causing folks to have to work at other sites. Now that folks have been told to stay one site only, it is causing financial issues with the staff, which again, unfortunately, is bringing them into the site feeling a little stressed out. So as they come in to deal with folks that are already dealing with cognitive issues and are very aware of the way the care that's being provided and how that caregiver is feeling, only through their body motions and the way that they whether they have the patience to help folks, it has certainly amplified the stressors that they feel. I'm watching a lot of our folks in dementia care just really struggling with the fact that they're not able to see their family members like they once did. And even though they may not be aware that that's what's making them feel that way, you can see it by their actions. And the elopement issues that we've been dealing with has certainly increased over the last 3 to 4 months. Again, I'm going to lean towards the lack of seeing family members and leaving them feeling lost and alone. Our staff are coming in, as I say, stressed out about the lack of monies that are available due to the fact they're one site specific. And those that are being asked to do overtime or offered to do overtime and accepting it are now, I'm watching about 3 to 4 months later, they're burning themselves out, which again is increasing the issues that we deal with in dementia care anyway, which again is to be able to provide care and to stay focused on the person instead of having to deal with their own issues. So at this point, I would have to say that the folks in dementia care that are living with us are struggling because of the lack of socializing, and the staff coming in are really struggling with their own fear of COVID, as Lisa was saying, financial issues, and then for those that are accepting the overtime that's being offered, the burnout side of it.
Okay.
Thank you.
Thanks, Brian. I'm going to move on to the next question, and I'm going to ask Shirley and Christine to speak to this. I think we can all acknowledge that our staffing shortages were there before COVID. I don't think there's any disagreement right across the board that existed. It wasn't created by COVID-19, but of course, as I think somebody mentioned, it's been exacerbated. It's been made worse by the pandemic. My question is, what pre-existing factors have contributed to our staffing challenges in our sector, in long-term care, in assisted living? What factors did exist, and how did we get here? How did we get to this place? Christine, I'm going to start with you.
Thank you. So I'll speak from the perspective of nursing, and perhaps I'll start at the macro level. The World Health Organization has identified that we are facing the largest worldwide nursing shortage, and within the next 10 years need 8 million more nurses worldwide. When we bring that back to Canada, we know from our own provincial government data that our own provincial government has estimated that we need 25,000 more nurses by the year 2030 to deliver care for patients in this province, and that's above what we currently have. So we already are struggling with a nursing shortage in this province. We also know from the CIHI data that we have the lowest per capita number of nurses currently working in healthcare in our province in comparison to all the provinces across Canada. So we already come from an area where we're a bit behind in a worldwide nursing shortage with no clear health human resource plan around nursing care in this province that has been organized by the government. There is no specific strategy on education, so increasing nursing seats in this province, no specific strategy that I'm aware of around recruitment and retention. And if we back those up and we go to retention, I'm part of that group. That's the 40% of nurses in this province that can retire in the next 10 years. So that gives you some of the sort of scope of how concerned we are about the nursing shortage going forward. The current nurses that are working in the system, I completely agree with my colleagues here. There are workload issues, there are environmental issues. Under COVID, we now have mental health issues, we have financial issues, there's so many other things. When we go back to, so we have to really look at what have we done to retain nurses in the long-term care sector. Interestingly enough, when you're a nurse, and we do represent 3 different divisions of nursing in this province. So unlike Ontario, we have licensed practical nurses. I believe the practical nurses there. We have registered nurses, and we have registered psychiatric nurses, which really do a lot of work in the world of dementia care. In this province, we have a 2-year and a 4-year program around education. So nurses don't grow overnight. It takes time. In those nursing programs, often aged care is very early on in the curriculum. And as I said, about 13% of nurses in Canada work in long-term care. The majority of nursing students look towards acute care as their future. And so it is the area that they tend to focus on, perhaps a little bit more of adrenaline in their mind. I moved obviously into the area of public health, also an area that isn't in high demand by nursing students. So we really have to look back very early on in how this started with looking at our nursing programs, looking at the opportunities that nursing students have to work in long-term care and with seniors. How do we make that attractive? And then when we actually go to retain or recruit the nurses into these areas, again, we've talked about things like wages and benefits, and certainly those in unionized environments have a situation that's slightly different than non-unionized environments. But those are all factors, working conditions, workload. And for many nurses, I do know we see often very few RNs working in long-term care, heavily dominated by the LPN sector. And so there can become nursing pressure to work beyond scope, to care for a more complex and ill population, and needing more support. So nurses will often move around to find those areas where they feel safe to practice. I think the one other piece around this is that I'm often contacted by nurses, internationally educated nurses, who are struggling to get licensed in this Canada because of limits through immigration or the National Nursing Assessment Service, that then step away from their perhaps registered nurse position to work either as care aides or licensed practical nurses while they're working through this process. So we do see a fair number of internationally educated nurses working in this sector, which I think also brings its own complications as they're trying to deal with a very complex healthcare system as well as adjusting to a new country.
Thank you. Shirley, I'd like to hear from you as well. I mean, what are your thoughts? I mean, your world is home health. What factors have contributed to in home health to the staffing challenges that you face?
Yeah, I think the key issue is, and probably the most simplistic way to describe it, is we simply haven't moved fast enough and far enough to actually pivot the healthcare system away from a very acute care model to one that is going to respond to not only the healthcare needs, but the life needs of the aging population. And the longer we wait, the more the problem becomes significant. And certainly with COVID, that has only added to the situation. We've been talking about problems related to care and services for the elderly for many, many, many years. I remember back in 2008 when I was seconded to the ministry in Ontario to look at long-term care and staffing standards. And I mean, the good news is that it was a great report. The bad news is that, now in 2020, we're still referring to the report that hasn't been fully implemented. But I joke with it, but there have been so many reports talking about the fact that we've got to get ahead of care and funding and services for the elderly. But I would say that we are still undervaluing services for the elder population, as you can hear from the other speakers, and we are underfunding them significantly. A number of reports, CD Howe, reinforce this issue, that we continue to fund per diem for the elder population in either home care or long-term care at a much lower rate than we would for seniors who require the same amount of care but happen to be in a hospital. I mean, additionally, we know that even those limited funds for seniors, 90% of them in Canada go to hospital and institutional care, and only 10% go to the community for services for the elder. That's very, very different in other countries that have a very different approach to care for seniors and the elder population. Now, I'm not suggesting that money is the solution to all of this, but what we sometimes forget when we talk about the issues that exist is that when the funding is limited, it impacts the staffing models that are put in place. It impacts the work environment that people have to practice in or provide care in. And then that obviously impacts the outcomes that people and their families have. So it really is a game of dominoes as to how this all plays out. And I think probably another very significant factor over time that hasn't allowed us to advance is this concept that there's this homogeneous phenomena called seniors or aging population, when, as we know, every individual has unique life circumstances and healthcare needs. So how we design an entire system around them, whether they're in the community, in their homes, in other retirement type settings, or happen to be with episodes of care in the hospital, we need to design these very, very differently and to, involve certainly the frontline, the clients and families, and the healthcare system to create the policies in a very different way than we now sort of go, all right, certain age, long-term care, this, home care, versus really customizing in a way that meets people's needs.
Thank you. I do want to follow up on something Christine said, but I'm going to wait because I want to make sure we get through all the questions. I want to get to maybe potentially some solutions at the end, so we'll come back to that. One of the questions I want to ask all of you is, we've been in this for, I can't believe it, 6 months. I was just counting on my fingers. And we've seen some changes. We've seen some significant changes to the way we provide care to older adults right across Canada. Some of them involve what we experience in BC and in Alberta, in Ontario and Alberta, is a single site that has had a significant impact. Hero pay in some places of Canada. We've all seen the increased use of PPE right across our spectrum. And then as Brian spoke to, the restrictions on visitation from family members and friends to residents. I guess the question here is, how have these changes affected our workforce? How has it affected the nurses? How has it affected home care? How has it affected the housekeepers? I mean, have these changes, and I guess the second part is, have these changes made things better or worse? Lisa, I'm going to start with you.
Well, yes and no. They've made them better and in some cases, some things have made it worse. So hero pay in Ontario is called pandemic pay. And I think that the $4 an hour that was provided to frontline workers in long-term care did make a difference to retain people who otherwise might have left the sector. And it also, interestingly, seemed to reduce absenteeism in the homes. However, that has now ended. The last period ended August 13th. So it was called pandemic pay, and we're still in a pandemic. So I don't know why it's ended. And I'm hoping that somehow it can come back, but I'm told it won't. And so the other issue with pandemic pay is that it did not go to management in Ontario, and it also didn't even go to managers who were working in the front lines. And that had a very demoralizing effect upon the management in the homes. And so it worked well, or to some extent, with frontline staff, but now it's very challenging for them because it's gone, and they're still working in very challenging conditions, and it has demoralized management. In Ontario, we also had something that was put in place. It was a regulation change because under the Long-Term Care Homes Act, only personal support workers and nurses could provide care to residents in long-term care. So that was loosened up with some flexibility, recognizing we could become short in those areas. And that has made a huge difference because we've been able to bring in personal support assistants, people who could have been redeployed from many different other sectors to help out in the homes with screening visitors, with helping organize visitation of families and other duties that are so essential. And increasingly, they will become used to actually provide care, assuming they get the right training, because we're going to see more and more, and we are seeing more and more shortages of staff as the pandemic goes on. And the increased use of PPE has definitely helped, for sure. At first, there was stories of workers wearing garbage bags because there were no robes, and having to wear masks for way too long. So that situation has improved, although it's very, very expensive. The PPEs are really draining the homes financially. And so the other thing that the restrictions on visitors and family members helped to keep COVID out, but we know that we just can't keep doing that. So in Ontario, the homes are somewhat opened up again because people were dying of loneliness as opposed to COVID. But once you open up the homes, then you know, even with certain controls in place, that still increases the risk that COVID could come back in. So, you know, there's two sides to that story, and it's definitely a very challenging situation. And then the other thing is that we used a lot of students in long-term care homes to help during outbreaks, and that made a big difference. But now a number of colleges and universities are saying that students cannot have placements in long-term care. And so homes are now losing their students, which is a big problem.
Wow. Sounds like you have lots of challenges in Ontario for sure. And yeah, thank you for sharing. I'm going to go to Christine and ask the same questions. You know, you've obviously been in the forefront of knowing all these changes that have happened in single site and the PPE use and so forth. How has it affected your members and the nurses that you represent?
Well, I'll speak to a few of the issues specifically, and I think we're going to talk about single site order a bit more, but certainly the single site order came in suddenly, and while it has a lot of benefit, there have been a lot of unintended consequences, particularly around nurses who had been working multiple sites, as we know, just to be able to earn a living, be able to put food on the table, pay the rent, and who are then now directed to work in one facility. What we discovered was certainly the single site order pulled a number of nursing hours out of the healthcare system. And so as we've heard from my colleagues here, certainly people are now being asked to work overtime in some sites, and yet in other sites I hear nurses still struggling to get the equivalent hours that they had been working when they worked at multiple sites. So it's a complex situation, the single site order. Definitely understand the rationale behind it, which is certainly to reduce the transmission rates of COVID from one site to another through healthcare worker transmission. But it did have a number of unintended consequences. In this province, pandemic pay, we also have called it that. It is being delivered differently across Canada. Interestingly enough, nurses have not received it in this province yet. It was announced, and there was an agreement that it would be paid, but nurses have not been paid that money yet, as have other healthcare providers and other people identified who will be receiving pandemic pay. My understanding is that should be paid out sometime in early October. So for many nurses, while they recognize that the public saw them as essential, and they were grateful for the 7 p.m. heroes salute with the banging of pots and pans and the recognition of how hard they've worked. Somewhat like Lisa said, in our case, it's kind of like the pandemic really happened and that money wasn't available then. The pandemic is continuing, and there's a lump sum payment that will happen in October. But what happens when the pandemic continues? So nurses are extremely stretched right now, and are seeing this payment as a value statement, that the public, that the government recognizes how hard they have worked. But I do agree there are many people who have worked extremely hard through this time, and how that distribution of that payment will take place has caused a fair amount of angst, and it's really nothing that I have any control over or any influence. It's simply a government decision, and so we're monitoring the situation closely. I've been very closely monitoring also PPE, personal protective equipment, and have early on had a number of conversations with Jennifer Lyle, CEO for BC Care Providers, or Safe Care BC, in regards to access for particularly the private long-term care facilities. As you know, as the COVID pandemic hit, we had a worldwide shortage of PPE, and everybody scrambling to access personal protective equipment, particularly N95 masks. For nurses, this has been perhaps one of the most difficult parts of this whole pandemic. We have always relied on our professional judgment to make a decision at the point of care what the appropriate level of PPE is to wear. And unfortunately, that decision seemed to be taken away from us, more about the cost, and we've heard about, and it is astronomical how costs have increased on personal protective equipment, and I think that's extremely unfortunate. It is a supply and demand issue, but also around access. So not only access for the employer, whether it's a private facility or any of our publicly funded facilities, to be able to access enough personal protective equipment so that they can provide what the nursing staff and other healthcare staff need, but also the access of the individual nurse to be able to access what they deem they need to keep themselves safe. And I will say that, we have extremely high levels of nurses who are reporting fear around contracting COVID in the workplace, bringing it home, bringing it to their communities, or even returning to work with it. Unbeknownst, we now know many people are asymptomatic carriers for a while. So again, and there's a lot of confusion around appropriate PPE usage, particularly the debate around aerosolized spread. And we recognize that the patients, the residents that are living in long-term care, have many more complex issues than perhaps they did of 20, 30 years ago. So, these people can be very, very sick, and nurses want to protect themselves, protect their other patients, and they simply want access to the appropriate PPE that they deem at their point of care risk assessment as a professional that they need to safely provide care for the patient and take care of themselves so that they don't become a victim of COVID too. So it really has become a challenge, personal protective equipment, and a point of anger, angst for nurses. Will there be enough PPE? Is it the appropriate PPE? Will I get access to it? Is my health and safety a priority, not only of the healthcare system or the healthcare facility, but the healthcare system? And I know all efforts are being made to access as much PPE as we can. But I'm reassured daily by the government that we have a lot, and I still just do not see nurses having the access they need. And that's extremely frustrating.
Thank you. Thank you. I'm going to go to Brian next on this discussion.
Certainly. I can speak of what it's like or what it's been like on the front lines. I know from our housekeeping staff through our nursing staff into our maintenance that just the use of PPEs all day long has created a lot of angst and a lot of extra stressors on our staff. I mean, when all of us have started in the business, we were told to offer care to people that may be compromised by utilizing new PPEs for each one of the residents / clients / patients. Now we're being told to use the same PPEs throughout the day, unless of course it gets moistened or things along that line. So speaking to what Christine was talking about having access to it, we have not at our site or the sites that I've been involved with ran into any shortages, but that's only through the grace of God and the fact that SafeCare and the government has jumped in to help us out where need be. I do see on the front lines the use of sick time. So people are calling in now with sore throats, again, possibly due to the masks, due to now we're dealing with smoke. And again, when they call in, they're being told, well, that's a symptom. You'll have to stay away and have a COVID test done. So we're taking people off the front lines in a larger number than we've ever done before. The sick calls are up exponentially, of course. And people are, as Christina was speaking of, people are quite fearful of the fact that, is this a sore throat caused due to wearing masks all day, or am I asymptomatic, or am I symptomatic? And do I need to really think about who I've been around and where I'm going to go after this? And none of us want to be the person that brings it into a site. So that's definitely been most of the angst that I've seen on the floor, is just the overwhelming fear and just getting tired of the PPEs. And we now are into the realization that this is going to be a part of our life for quite a while. And again, now speaking of the hero pay, that one I have to lean a little bit with on the side of, I wish the government hadn't announced it as early as they did, unless they were willing to give it away within a shorter period of time, because as Christine said, we've yet to receive it here. So those on the front lines that I certainly work with were quite excited, felt validated. It was very nice to see what that did and how it actually brought the morale up. But here it is months later, and people are feeling a little discouraged with the fact that it was offered, but it is yet to be distributed. So something that started off as a real positive has turned into be quite a negative, unfortunately. And really, it's out of everybody's hands at this point, certainly at my level. So that's what I've noticed about where we are at this point.
Thanks, Brian. And last word on this question goes to Shirley.
Thanks. I think I'll sort of lift it up a bit from a system point of view of, what's been, on one hand, I call it the doom and gloom of home care and the community and what we're doing. And the flip side of that is just wild excitement we have that finally some things may actually change. And unfortunately, it's taken a pandemic to make that happen. But I'll start with, some of the challenges, and I would say that these I have observed global. So it's not a Canadian phenomena, but a global phenomena, that with the pandemic, here's the irony: everybody stay home, everybody socially distance, but we're not going to have any care for anybody in the home. So quite a bizarre set of circumstances within that. I would say throughout the country, a lot of the home care shut down. And we saw in other countries too, Italy, Spain, which understandably a real preoccupation about hospital capacity and the thinking that we'll kind of shut down primary care and home care and community services for people, and we'll create all of this capacity, and then people will either be able to go into the hospital effectively, etc. And that thesis was flawed. In particular, in Ontario and in other jurisdictions where, by virtue of decreasing services for people, we actually decreased capacity, and that people didn't have the work. So people were laid off and were needing to access either unemployment or other types of support. So it was an interesting irony of, well, we'll create capacity, and by reducing and eliminating services for people, we actually had the unintended consequences that there were actually less people available. SE Health alone, and there were many other organizations in our same situation, we had at one time over 2,000 employees that were on, some form of leave of absence because there was no work. Now, think about that in the middle of sort of COVID. However, I think we're learning, and volumes have come up. In some areas, volumes were down as low as 70%. So you can imagine the destabilization with not only the workforce, but organizations, etc. So it's been quite a challenge. And I think in addition to what we're learning in Canada, other countries have learned you've got to make sure this is a system-wide approach to make sure there's capacity in the hospitals and in long-term care, in the community, and in home care. All of them need to be addressed, and in particular primary care too. Now, let me talk about the wild excitement, because I think that's important. That I think through the opportunity to look at things differently, the collaboration and the creativity that I have seen from the home care workforce has been quite amazing for me, where we've been able to compromise and modify some of our sort of solutions for people in their home, or how we're providing services in other facilities. I have been so amazed and impressed by the level of creativity that exists. I would say I've not been surprised, because I was always well aware that if you give people enough freedom, they'll come up with some great solutions. I think the other thing I'm very, very excited about is it only took, I don't know, maybe 15 years to actually move away from direct visits to now virtual visits. We never even moved to phone visits. We've had typically a reimbursement model that's been on a direct care. And overnight, we were able to move into virtual care, which I think is an amazing opportunity to maximize capacity of the workforce, also access to people, and an option when we're really concerned about infection control and the spread of COVID. And I hope that this is something that we never go back, and that we really look at, what are the various forms and variety of care and services that people can have. What I do and reinforce with sort of the professional practice mode, with both making decisions about PPE and what's necessary, I feel the same way with the types of care, whether it's virtual care or direct care or intervention. You want to make that decision as close to the direct clinician and the client and family as much as possible. That's the only concern I have, that we'll begin to have everything be more of a virtual visit, where I think it's a combination of certainly the clinician's judgment and of course the family and client's judgment and choice of what they would like to have. So I think that's been extremely, as I say, rewarding to me, because for years we were talking about how to modify the kinds of visits that we have. And I think, lastly, it's I think an opportunity finally to, with both long-term care and home care in the community, to shift how we value and look at care for people, and that we stop a total preoccupation at times of a very acute hospital-centric to what are the needs for increased compensation for people in these settings that are as important and as valuable as acute care settings. And I think that this opportunity is providing, I think, finally some doors opening and maybe some windows opening to see that we have to look at these other areas as and make them as robust as we have some other parts of our healthcare system.
Thank you. That's a good segue into the next question, and I'm gonna this one's for Lisa and Christine. We're talking about single site staffing, and really the question is twofold. Do you think the governments should keep single site staffing in place? And part B, if so, what can we do to minimize the impact, the negative impact on recruitment and retention? Because that's what we're feeling right now. So Christine, I'm going to start with you.
Great, thank you. Difficult question, right? Pros and cons to both. As a public health nurse, somebody who's been involved in infection control, somebody who spent her whole career waiting for the pandemic, and here it is. I really do understand the need for a single site order. Again, as an infection control method, we do know viruses don't transmit unless people move. So people moving from facility to facility, particularly with our vulnerable population, it is fraught, to increase infection rates. And so I really do understand it from that perspective. So I appreciate in this province, Dr. Boddy Henry taking the lead on that. The problem is that it certainly has labor relations related issues. And so there was the need to sort of sit down and work with the respective unions to talk about the impact of a single site order and really how to implement, roll this out over a period of time. And so in this province, it didn't really happen overnight. It started on some health authorities, then became a provincial health officer order, and then each health authority sort of came in line and facilities sort of came into line. Again, many unintended consequences. We did not realize how many people were working at so many multiple sites, and the fact that some of these people were working up to 1.7 FTE. This was particularly prominent in the metropolitan area of the Lower Mainland of British Columbia, where people could work at multiple sites. Less so in rural and remote areas around the province, in the Interior Health, Northern Health, parts of Vancouver Island. But again, a lot of the drivers around this are the cost of living in Vancouver and people simply needing to put food on the table and a roof over their heads. So moving people then to sites, people asked to go to certain sites or requested or listed their priorities, but that didn't necessarily happen. So again, unintended consequences. And we're still working through some of the labor relations issues around people who now want to move from, say, site A, where they were assigned, to site B, which is really the site they wanted to be, but because they worked at both A and B, somebody magically decided and put them in a spot. That's caused, a lot of frustration. Teams were split up, so interpersonal teams with healthcare providers, as well as, we should, respect people's own initiative and career paths and where they, feel that they can best contribute to their workforce and the care that they provide. It really is a betwixt and between. We need it in some respects, but it certainly had an impact on the workforce. I am aware that in one province, they did look at implementing a single site order in 3 units in an acute care model, and very quickly managers pulled back on that because they realized that they absolutely did not have the acute care staff to move the entire acute care system to single site. And so there's learnings that have come from the single site order in long-term care that do not apply well to acute care. And it goes back to the nursing shortage and the fact that we just don't have enough nurses. And then those that were cohorted to one site, unfortunately for many of them, aren't working up to what they were before and have received actually, because I think the maximum is 1.3 FTE at straight time. So many of these people are not able to meet their financial commitments from prior to when they were working multiple sites.
Thank you. I want to get the Ontario version. And Lisa, do you think the Ontario government should retain single sites, and how do we minimize the impact on healthcare workers?
I think the notion of single sites worked well and was very important at the beginning, but things are different now. So keeping in mind that half of the workers, in long-term care in Ontario are part-time, by telling them that they can only work in one site, unless they're able to get full-time employment in that site, that has meant that workers have now gone and worked in other settings. They're working in Walmart, they're working in bars, they're working in grocery stores, they're working all over the place. And a lot of our members are saying to us that the workers are actually working in places that are higher risk than long-term care. And in fact, it would be better if they could work in another long-term care site now that we've opened up again, although things might start to close somewhat. So in the context of a more open environment, I think that we need to really look at this. And one of the solutions that we've brought forward to government is that homes should be allowed to create bubbles, which is something we've been doing in Ontario with people informally. Say you could be in, find 10 people and you can be in that bubble so that you can be together with them. So what we're saying is create bubbles of long-term care organizations where 2 homes, for example, could share staff between them and share their IPAC expertise and knowledge of outbreaks, etc. So that way you have more options. That doesn't mean to say if you have a large chain with 50 homes that a worker can work in any of those 50 homes. Like, you need to manage your bubble well. But it seems that that might be the best compromise, because we do need to be careful and control things, but we also have to recognize that people need to have enough employment. And until such time as we can get enough funding to give people a living wage and have them work the hours that they need to work, then we need to have other options that are available.
Thank you. We're going to turn our minds to recruitment, because that's what we're obviously talking about here as well. We've identified a lot of the challenges, and so we've only got a few minutes left. We've got about 8 minutes left, and I definitely want to speak to this. So this question is for all of you, and I'd ask just to keep it as brief as you can. What, in your opinion, are the biggest opportunities for us to recruit qualified people into seniors care? I'm going to start with you, Brian. You're a frontline guy. What's our biggest opportunity to recruit new people into the industry?
Well, thank you very much. At this point, seeing the amount of other careers and job choices have sort of dwindled away for a lot of the population. We've lost a lot of folks in retail and just a host of restaurant type jobs. I mean, there are an awful lot of people out there that are now looking for work. And I believe that if we were to get out there and do a really good job at recruitment, and that means finding the right people. I'm not saying just bring bodies in. We don't just need bodies. We need people that actually want to come into this field, but possibly have never thought about it or were quite content wherever they were. Are now might be searching around for a new career path. And I think we have a golden opportunity now to take advantage of these huge amount of folks that are looking for new opportunities and new career paths. And I believe with the support of the government financially, and with a really good recruitment plan and getting out there and talking about the advantages of choosing healthcare as a profession and the fulfillment that each one of us feel, and the advancement that can be made throughout your career in healthcare, I think would speak highly, or speak to the recruitment factor. And I don't know. I think we've got a golden opportunity right now. I don't see this as being a negative. I see so many people out there that are unemployed right at this point, or laid off for one reason or another, that are now trying to decide, what am I going to do? Well, this could be their path, and this is where I want them to come.
Yeah. All right. Well said, Brian. Well said. Shirley, I'm going to turn to you in home health. What do you think are opportunities in your world to recruit new people into home health?
Yeah, I think I'll answer it not just from home health, but I would say just the whole long-term care system in general. I think first and foremost, we actually need to fix the system. We need to make sure that we're funding it effectively, and that in fact we're providing work environments for people where they are fulfilled, empowered, all those kinds of things. Like everything else, if we don't fix it, no matter how we kind of try to make it look great. When people come into the area, they're going to say, I want to move on to something else. So that's absolutely paramount. Secondly, what we've been trying to do as an organization, in particular from a home care point of view, is over many years, we actually invested a lot of our time and energy and created a ministry-approved training program for personal support workers and have our own SE Health Career College. And what we have been doing is using this career college to, in fact, help us with our own pipeline, but also to help educate personal support workers in the home care system in general. So actually many of our competitors were helping them recruit individuals into the educational program. And we have created a very interesting design for personal support workers to come into a program where they're able to continue to work as what we would call home support workers, while they are also learning and positioning to be what would be in other provinces healthcare aides or personal support workers. And then many of them are, of course, hired and remain in the home care organizations. So right from the get-go, they have incentives to move into this area of education. It gives them exposure immediately to this environment and to different organizations that they choose to stay with. And allows us, I think, to quickly begin to look at new approaches to educate and develop, in particular, personal support workers in this space. And I think we need very creative and different programs that help bring people and younger people, second career, all different groups into this setting. But until we fix the system, and by that I mean begin to value it effectively and begin to fund it effectively, no matter how creative and innovative and amazing we are to get them in the front door, they're going to leave very, very quickly through the back door unless, and I would say the collective we, which is all of us working in the health system, governments, etc., really begin to make some of those fundamental changes that are critical.
Thank you. I'm gonna turn it to Lisa. Turn to you in terms of. I'd love to hear the Ontario perspective. I mean, what's Ontario going to do to look at the opportunities to recruit people into seniors care?
Well, we have been asking government for HR solutions, and we're still waiting for them. So it's somewhat frustrating, but I do hear things are coming. So I can't speak for what the province is going to roll out, but I would agree with a lot of what the other speakers have said. And we need to have 4 hours of care at least, which is what Shirley recommended in 2008, and we still don't have, because otherwise you're going to bring people in, like she said, and they're going to run away with their hair standing on end when they see how burnt out they can get working in an environment where there aren't enough staff. But I think things like apprenticeships should be done for personal support workers so they get that on-the-job training. Living classrooms is something that we've been doing in Ontario, so that when people are trained as PSWs, they're in a long-term care home at the same time, and they see what the environment is like, so they're not in complete shock when they become hired in that environment, and they're able to handle it better and stay. And also preceptorships for PSWs so that you can have mentors and they can help one another. And the other thing that we haven't talked about yet is foreign trained workers and or foreign trained healthcare professionals, and how that's a great opportunity that we need to take a look at to see how we can work with those individuals and bring them into long-term care.
Just a follow-up question, Lisa. Has any work been done in Ontario to speak to the federal government in terms of advocating for foreign trained workers to be sort of the red tape to be reduced?
Not as far as I know from the provincial government, but we've tried to speak with them about changing the National Occupation Classification Codes so that we create two kinds of codes for personal support workers so that we can get more in, so that there's sort of like a personal support worker extra kind of position that would allow more people to come in and have a more qualified personal support worker to deal with higher acuity residents. And there has been interest in that at the federal level, but I haven't seen any movement on that yet.
And the last word goes to you, Christine. What are the opportunities to recruit more people into the industry?
Well, I'll be very quick. I agree with everything that's been said. I'm a believer that there's no point in recruiting unless you learn to retain. There have been measures in this province to try to retain the workforce, and I do think the single site order and the compensation leveling has been helpful. We do need a health human resource plan specific to nursing, but really specific. We need a health human resource plan to really look at, long-term care, really the pipeline. I too am a fan of these dual credit programs early on. I think there's lots of young people who are, trying to figure out their future. And so we could certainly involve them right out of high school, and that enters them in the pipeline. And even one day, maybe those people will move on to become nurses. So we do need to look at a stepping sort of program to support those people who want to work through, from a support worker to a care aide to a licensed practical nurse, those things all the way along. And so that we can look at, successorship planning in our healthcare system and retaining more of the nurses that we currently have. And I've already spoken about internationally educated nurses. I think we have a real problem nationally on a block to allowing internationally educated nurses who are qualified to work in this country to get here quick enough.
Thank you. Thank you for that. And our time is up. I want to take this opportunity to thank you, Christine, Lisa, Brian, and Shirley for your insightful comments and thoughts. Thank you for just engaging us in providing some insight into the challenges, but yet to offer some solutions. And it's not all about money. It's about changing the system, which I think that's what we all want. And if there's any silver lining to COVID, it's forcing us to have that conversation now. And hopeful, and I think the governments are open to having that conversation now because it is so public, it is so in front of us, and we're all hopeful, I think, on this presentation that we see meaningful change come in the coming months. So again, thank you for all being here, and have yourself a great day.
Thank you.
Great,
You too.
thank you.
Thank you very much.
Bye now.
Bye now.